Welcome everyone to the Team Science Virtual Seminar Series, sponsored by the NJAX Team Science Core. My name is Dan Horton. I'm one of the co-leaders of the Team Science Core, along with Nancy Reichman and Ralph Gelati. So maybe some of you have seen other editions of this series, but for those who are new, this seminar series deals with hearing from different transdisciplinary research teams within the NJAX Consortium to learn about how complex biomedical research teams form, operate, and achieve success. So in each of these seminars, we focus on a different team that's generally funded by a federal mechanism that's designed to promote and foster high impact transdisciplinary research like R01s, U01s, P-Series program project and center grants. And so we ask our speakers to give high level overviews of their project and then comment on different aspects of their own experience in team-based research, including advantages and challenges of interdisciplinary team research, important competencies for leading effective research teams, and useful strategies for fostering effective collaboration. With that, I'll turn over to Ralph to introduce today's speaker.
Great. Hi, everyone. It's my pleasure to introduce Dr. Jeffrey Carson, who serves as the Provost of New Brunswick at Rutgers Biomedical and Health Sciences and served as Chief of the Division of General Internal Medicine until 2015. Dr. Carson is currently the Distinguished Professor of Medicine and Richard C. Reynolds Chair in General Internal Medicine. Dr. Carson is a board-certified internist who practices office and hospital-based internal medicine. He has been awarded 5 teaching awards and been on the annual Best Doctor list since 1998. Dr. Carson's expertise in clinical trials, as we'll be hearing more about today, has been recognized by his appointment to Clinical Trials Review Committee at the National Heart, Lung, and Blood Institutes, where he served as chair during his 5th year. He has served as a member and chair of multiple clinical trial data safety monitoring boards. Lastly, the focus of Dr. Carson's research is on determining the risk of anemia and indication for blood transfusions. His work has been published in a number of the most influential medical journals. So Jeff, thanks so much for joining us today. We're looking forward to your presentation.
Well, thank you, Ralph, and Nancy and Dan. Thank you for having me. You're talking, this series is about team science, and there is nothing more representative of team science than clinical trials. I mean, this is a group project. And while, I may be the study chair and principal investigator of my current trial, which I'm going to show you, that's called MINT, there's not a chance in the world this would ever be successful without a huge amount of effort by many, many people. And I'm going to show you that. So to try to make this relevant, I'm going to give you a little bit of a clinical talk to set the scene for this, and then we'll go into the details of a little bit about how the trial is organized, the numbers of people and their roles that make this trial successful. With that introduction, then let's go forward. So the trial is called MINT, Myocardial Ischemia and Transfusion. For anybody who's ever been involved with clinical trials, you got to have a name. And as I like to say, this was a 2-conference call name. It took us a while to come up with it. So the aims of this trial are to determine whether a liberal transfusion strategy, which uses a threshold of 10 grams per deciliter, so this is a hemoglobin level, whether this liberal transfusion strategy reduces the 30-day composite outcome of all-cause mortality or non-fatal myocardial reinfarction. So this is the primary outcome, compared to a restrictive transfusion strategy with a threshold of 7 to 8 grams per deciliter. So we're comparing people who are transfused with more blood, so-called liberal transfusion at a higher threshold, to those who receive less blood with a restrictive transfusion threshold of 7 to 8. And we're trying to enroll 3,500 patients with acute myocardial infarction and they're eligible if they have a hemoglobin less than 10. So if you understand this one statement, you actually have many of the, almost all the key elements of this trial. And we're going to come back to that soon. So, why is this important? Well, it turns out that blood transfusion is one of the most common medical interventions in any hospital. In the US, over 16 million units of blood are transfused annually. Worldwide, over 100 million units are collected and transfused. It turns out that a lot of the patients who get blood have underlying heart disease. And of those patients who have heart disease and have had a heart attack, so myocardial infarction is a heart attack, 20 to 25% of those people have a hemoglobin less than 10. So this trial is targeted at a common population of patients who often get blood transfusion. So if I was to take you to the bedside and say, well, you have to decide, if you're a clinician trying to take care of a patient, decide whether or not to give transfusion or not. Like every medical decision, you're going to be weighing the risks and the benefits. And the risk side of the equation is the side effects of blood and the risks related to anemia. And if you give blood, you're hoping you're going to benefit that patient both on mortality, morbidity, and then some quality of life measures, including functional recovery. Now, I'm going to go through this a little bit, but very briefly. So I'm not going to touch much on the side effects of blood other than to say that the risks of blood from known problems actually is very low and comparable to everyday risks. And in my view, and I will tell you that this is not necessarily a view that everyone accepts, when considering whether to transfuse, it really is not about the risk, even though people like to talk about HIV and hepatitis and so forth, but those risks are very low. They're less than 1 in 2 million. So I don't think they're clinically relevant. And therefore, I think what matters as to determining whether you give a unit of blood is whether it works, whether it improves clinical outcomes. And then you have to consider other things like cost and the fact that blood is a finite resource. So, this is a key part of this risk side of the equation. But the second part is the risk of anemia. And we have data that actually was my very first NIH grant way back. We published it way back in 1996. This is a cohort study of patients who decline blood for religious reasons. So these are patients of the Jehovah's Witness faith. And we followed a group of those people who underwent surgery in an operating room, and we looked at their mortality and morbidity. And it turns out that cardiovascular disease is important, and I'm going to show you that in a minute. And we were able to enroll into this cohort study almost 2,000 patients, 18 years of age or older. And the key finding is on this graph in which we plot the adjusted odds of death compared to the preoperative hemoglobin. And here in blue are patients without cardiovascular disease, and here in red are patients with cardiovascular disease. And what you can see is that the odds of death rises whether you have with or without cardiovascular disease, but in those patients with cardiovascular disease, that risk of death rises much more rapidly than patients without cardiovascular disease. And this, in fact, was significant for a test for interaction of 0.03. Now, it's important to emphasize that this does not say that giving blood transfusion will modify that risk, right? It only says that if you choose not to take blood and you have underlying heart disease, your tolerance of anemia appears to be different if you have cardiovascular disease than if you don't. So we would conclude that mortality and morbidity rises as the hemoglobin falls, and human data suggests that patients with cardiovascular disease may be less tolerant of anemia than patients without cardiovascular disease. But as I said, it's good. It's nice to identify a high-risk group, but in the end, you have to establish that giving blood or giving more blood improves outcomes, and this you need clinical trials to prove. So we have been doing systematic reviews of the literature, summarizing clinical trial data for, I don't know, we've probably done 6 or 7 of these versions. The last version we published in December of last year in the Cochrane database. It includes 47 trials, which were evaluating thresholds. And basically what that data shows is that using less blood, which we call restricted transfusion, with a threshold of 7 to 8 is as safe as a 10 threshold, looking at the 30-day mortality. And here is a forest plot looking at that. And to orient you, here are the individual trials. Here you can see a column with restrictive transfusion. Here is liberal transfusion, the relative risk, and then this is just graphically displayed. Here are all the trials that have been performed. And you can see if you look at 30-day mortality, which is our primary outcome here, there's over 16,000 patients who've been enrolled in these trials. And lo and behold, the relative risk was 1.00 with very tight confidence intervals between 0.86 and 1.16. So these results suggest that overall, using less blood neither increases mortality or decreases mortality. Now, that's very nice, but that provides the overall risk. What about special groups of patients? So we went off and did a pilot study, and that pilot study was also funded by NIH. This was done during, those of you who may remember that when there was a big drop in the economy and the federal government gave a lot of money to the NIH and they did what were so-called challenge grants. We were able to get funded for a pilot study, which was the MIT pilot. You can see here, we enrolled 110 patients. The one patient lost to follow-up. And in that pilot study, we had as our primary outcome of death or recurrent heart attack or requiring revascularization. So that would mean that they would have they get a cardiac catheterization, they get a stent opening up a blood vessel, or they would go to cardiac surgery. And what you can see here is the group that got more blood had an event rate of 10.9%, and the group that got less blood had almost a 26% event rate for death MI or unscheduled revascularization. And what's even more striking is if you just look at death, that one patient died in the liberal group, the group that got more blood, and 7 patients died in the group that got less blood, so-called restrictive transfusion. And oh my, that looks like there's a big difference here. And so these pilot results were then included in a grant application that we sent to the NIH saying, look, it may be in fact that overall there's no benefit from giving more blood, so-called liberal transfusion than restrictive transfusion. But we know that patients with underlying cardiovascular disease could be different. And here is evidence that suggests that might be the case. And we better go off and do a big trial. And that was how we were able to convince the NIH to spend a lot of money to support this trial. Now, as I said, when you look at mortality, and actually most of the morbidity data also doesn't show an effect, but there are clinical practice guidelines that have come out. And you can see this is one that we published back in 2016 in JAMA. This was also a review that we had an invited review at the New England Journal of Medicine. And what all these documents say is, yes, use less blood, use a restrictive transfusion strategy, but we don't know whether patients with underlying heart disease, especially those with acute myocardial infarction or having heart attacks, we don't know if that group of patients might not be benefited by using more blood. And this pilot data that I just showed you certainly raises that hypothesis. And there's other evidence that I don't have time to show you, suggesting that maybe we should be using more blood in these high-risk groups of patients. And that's what these guidelines say. Of course, I wrote some of these guidelines, so you can decide what that means. But nevertheless, I think it was widely accepted that patients with underlying heart disease could be different. All right, so that's a very quick background. Blood is commonly used. Most of the data suggests you can use lower thresholds, but there could be some high-risk groups that maybe you should be using higher thresholds. And we are going to test that in the MINT trial. Okay, so who's included in this trial? Well, we have people who are 18 years of age or older. We have no upper age range. We'll take anyone, no matter how old, that they have what's called an ST segment elevated MI or a non-ST segment elevated MI. And this is consistent with what's called the third universal definition of myocardial infarction criteria. There's now a fourth version of this. These are research criteria for the diagnosis of acute myocardial infarction that's widely accepted. And in the research community, this is how you define the presence or absence of an MI. And in fact, these criteria are also used clinically. Now, there's different kinds of MIs here, and I'm not going to spend time going through those with you. But there's certain different types, and we included most of them, but not all the types of MI. And then these patients had to have a hemoglobin level less than 10 at the time of randomization. So these people could be admitted with higher hemoglobins, they could bleed, and then their hemoglobin be less than 10, and then they would be eligible to be enrolled in the trial. Now, we excluded patients who were undergoing cardiac surgery during this admission if they had uncontrolled bleeding at the time of randomization, although we would take patients enrolled after they stopped bleeding, they would still be eligible. The primary outcome, as I told you in the very first slide on specific aims, is a composite of all-cause mortality or non-fatal myocardial reinfarction through 30 days following randomization. Now, I should tell you that this occurs somewhere around 17 to 18% of patients within 30 days. Now, what you may not know is that the risk of dying from an MI is really pretty low. It's less than 5% or so, okay? But when you take a patient who is anemic, okay, and has had an MI, that changes the risk dramatically. That overall the risk of dying or having a recurrent heart attack is 17 to 18%. So we have chosen a very sick group of patients with a very high risk of something bad happening to them. Now, that's not good for them. From a trial perspective, that means that that gives us enough events where we can study this with a I don't know, not that 3,500 patients is a modest sample size. It's a big sample size, but we don't need 10,000 patients, okay, which you can need in some big trials. So we're randomizing people at the time. So they come in, they get consented. We talk to their doctor and get permission to approach those patients. And then typically a research coordinator will go and consent the patient. If they agree to be in the trial, then the patient is randomized. So they flip a coin and they get randomized to two pragmatic transfusion protocols. The first is the so-called restrictive transfusion strategy. This is the lower hemoglobin level, and they're permitted to receive a transfusion if the hemoglobin is less than 8, and will be strongly recommended to receive a transfusion if it's less than 7. So they are not required. We do not require the docs to give blood below 8. They are allowed to give blood below 8. So they can choose to give it at 7.9. They may want to wait till 6.9. They may not want to give the blood at all, which probably is not a good idea, but the protocol does not require them to give blood. It just allows them to give blood if they choose to give it when it's less than 8 grams. And transfusions also permitted if they develop symptoms such as chest pain that's thought to be from the heart, so-called angina, and that the clinician thinks is related to anemia and has not been controlled by increasing the medicines, anti-anginal medicines. The liberal transfusion group's pretty straightforward. You receive 1 unit of blood following randomization, enough blood to keep the hemoglobin above 10 at any time the concentration falls below 10. So during the first 30 days or while they're in the hospital, up to when they're discharged, that if the hemoglobin's less than 10, the protocol calls that they get a unit of blood and then a post-transfusion hemoglobin that documents that their hemoglobin's above 10. So this is a 10 versus 8 trial. And then if, by chance, someone gets sick and starts to bleed like crazy, okay, the hemorrhage, then when we stop the transfusion protocol, and the clinicians may give blood under any circumstances, regardless of what the hemoglobin level is. So this is one of the pragmatic parts of the trial that we try to emulate what goes on in real clinical practice. Okay, so That's very, very brief overview of the way the trial works. I should add a couple more things before I talk about enrollment. That after the patient we measure blood work and what's called a troponin, where we're looking for recurrent heart attacks. We're doing EKGs looking for recurrent heart attacks, and then we're classifying whether the patient has had a recurrent heart attack or many other complications. So I haven't told you about all the other outcomes like heart failure and infection and quality of life. We measure a whole bunch of things, and we measure them up to 30 days. And then and we telephone people if they've left the hospital 30 days to document that they're alive. And if they've been readmitted to the hospital, then we go look at their medical records to see if they've had any of these complications that I just alluded to. We also call people at 6 months to determine their vital status. And that's pretty much all the follow-up we do in this trial. Okay, so that's very briefly how the trial works, and I'm happy to answer any questions later if you have any about some of the particulars of the study, but I wanted just to sort of give you the overview with not getting too far into the details unless people are interested. So, enrolling 3,500 patients, let me tell you, this is hard. This is really, really hard. And so this trial was organized initially to include about 80 centers in the United States and Canada. And so we were originally going to do just in the United States and Canada. And we started enrolling patients here in March of 17. There were only a portion of the sites that were active. By the following year, we were enrolling 50 patients a month, and then 56 patients or so a month. And then guess what? COVID hit. And like much of life, clinical trials shut down for a while, and we shut down this trial for a couple months. And we had a lot of trouble recruiting during the peak of the COVID pandemic, right? And not surprising, it's not like people didn't continue to have heart attacks, but they weren't coming to the hospital as much. and it probably reflects the reason why mortality was higher. And in any case, you can see our recruitment fell. Now, when this happened, it wasn't too hard to predict that we were going to fall behind in our recruitment requirements to complete this trial within the allotted time. I went out and through my steering committee, executive committee, who include a number of prominent cardiologists who know lots of people all over the world, we also expanded the trial. So from the US and Canada, we expanded the trial from 80 centers to include sites, 15 sites in Brazil, to include about 15, 18 sites in France, to include about, I don't know, a half a dozen sites in New Zealand, and about it turned out only 4 or 5 sites in Australia. We were expecting more, but for other, for issues that I don't want to bother spending time on, they weren't very successful with the trial. And we have opened up 145 hospital sites around the world to try to get our numbers to get to our 3,500 patients. And so you can see, this is a slide that we produced for the NIH, showing them that, yes, we were making good progress, but COVID messed us up. And oh, by the way, we need some more money to be able to finish this trial. And thank goodness we were actually successful after 2 attempts to get some further support from the NIH to finish the trial. So another way to look at this is these accrual curves. And here you can see here on the x-axis, the dates, okay, and then the number of patients. So we're trying to get to 3,500. Now this slide is from October of last year when we had 3,145 patients. So you might want to know, where are we today? Well, we only need to recruit 120 more patients into the study, and we will get to the magic 3,500 patients. And I believe we will get there sometime in April. I don't think we're going to make it at March 31st. I think we'll probably need 3 weeks in April to get to 3,500 patients. But we are almost there, which is very exciting to me. All right, so conclusions are in patients with acute MI, we do not have high quality evidence to guide clinical practice. There was a signal in that patients with acute MI might benefit from higher thresholds. And we think the MENT trial has the potential to have a high impact on clinical practice by generating the necessary data to guide transfusion decisions in this high risk common group of patients. So that is the brief summary of the paper. Now I want to go through the organization. I have that on a different set of slides. How is a clinical trial that's funded by the NIH organized? Okay. Well, everything, of course, starts with the people with the money, right? So that's the NIH. Okay. And we have a project officer who provides oversight for the entire trial. And the blood division of the NHLBI provides the oversight for this trial. Now, the second level of oversight is what's called a Data Safety Monitoring Board, or abbreviated DSMB. Most clinical trials of any size have an independent group of experts. In this case, they were chosen by the NIH, and they have several roles to play. So the first is that before we can start, they have to say, yes, you're ready to start. Okay, so they review all the protocol, they give us suggestions, some that we don't like, but most that we did. And so we modified what they, a little bit about the protocol. And so they approve us starting. And then what they do is they monitor patient safety. So their most important role in a clinical trial is to look at the data as it accumulates. And in this trial, they look at it every 6 months, okay? And they're looking to see if there's any signals that the patients are being harmed by this trial, okay? So they are looking at unblinded results. In contrast, I have been at this forever, and I have no idea what the results are, okay? I'm totally blinded until probably this summer when I finally get a look at how the trial's coming out. But the DSMB is responsible in making sure patients are not harmed. The other thing the two other things they do is they want to make sure that we're implementing the protocol properly. So we have every 6 months we have a meeting with them, a call. It's all Zoom now, and in fact we will be doing that in another week and a half or so for what will be our last DSMB call, I believe, where we present what's going on, and then they look at, and they do that. There's 2 steps of that. There's what's called the open book, in which I present and one of the statisticians presents where we are with the trial, and then they go into closed session, and then they get to look at the results of the study as it accumulates to fulfill their primary obligation to be sure that there's no problems with patient safety. Now, the other thing they do is that we have a plan in this trial that says if at some point before the trial is finished, it is clear that one arm of the trial, either liberal or restrictive, is superior to the other trial, that you've convincingly demonstrated unequivocally that one group is superior, it's no longer ethical to continue to enroll patients, and therefore the trial is stopped. Okay, so they're looking at it, and they have the ability to recommend to the NIH that the trial should be stopped because the question has been answered that one group is superior to the other group. Now, they haven't done that yet, so and they won't do it because we're almost at the end, of course. So, but that is a critical role for the DSMB. And so this is, once again, this is made up of, in our trial, there's cardiologists on this committee. There are blood transfusion experts on this group. There are statisticians, there's an ethicist, and the committee is actually fairly big here. I don't know, it's like 8-10 people. Very good group who've given us lots of good advice and have been a total pleasure to work with. All right, so that's kind of outside of the main study group. Then we move into the individuals involved with it. This is the organization. So you already can see there's a ton of people just at the NIH and the DSMB involved with this. So we're talking about team science. This is the definition of team science, but wait till you see how many more people are involved with. So we have a leadership group, which we call a steering committee and executive committee. So in the way we have this organized, we have a very small group for the executive committee. It's like 5 or 6 people. This is where the highest level, most important decisions are made. They help me put this trial methods together, design this study. And then we have a bigger group, which is of the steering, which is called the steering committee. And we basically meet with each of these groups once a month at least. People on the executive committee are also part of the steering committee. And we have calls talking about issues all the time. We have a call at least once or twice a month on Friday mornings at 8 o'clock. We have a call tomorrow morning at 8 o'clock. And, you know, and we're going to be talking about different things. So, you know, it depends where we are with the trial. Almost always we're talking about recruitment because that is the most challenging part of getting these trials done. But, you know, we're now planning how we're going to publish it, where we're going to present this. What are the different papers that we might want to write, for example? So there's a lot of effort that goes into planning and trying to execute this trial. All right, so that's the leadership group. Then you can see the next bullet, it says Clinical Coordinating Center and Data Coordinating Center. So the way trials are organized at the NIH is that you have one group who is responsible in interfacing with all the hospitals, all the doctors, all the research coordinators, and in this case, at 148 centers around the world. And the job of the Clinical Coordinating Center is to find these sites, to train them, and to help them conduct the trial. Okay, so the Clinical Coordinating Center is here at Rutgers. You know, I'm chair of that Clinical Coordinating Center, both as the study chairman, but of the Clinical Coordinating Center. And I have a team that works with me. I'm going to show you some of their names in a minute. It's a very small team, actually, of just 3 or 4 people and we work with all the sites to get them to do the trial. Now, when they conducted the trial, there's the data has to be managed, okay? And so that data is submitted electronically to what's called the Data Coordinating Center. And that Data Coordinating Center in this trial is at the University of Pittsburgh, led by Maria Brooks, who is a clinical trialist statistician. And she has an army of people that work for her, including statisticians, including computer data analysts, and then people who do a lot of the administrative work as well. But their basic job is to take the data after it's been collected by the sites to put it in the computer, of course, to look for accuracy for problems that might exist with the data. And so we call that cleaning. So they have to clean the data. They often are sending back queries to each of the sites saying, you know, this doesn't make sense. You're missing some data here. And please give us the follow-up information right with this and so that at the end of it, when we have a data, it's been carefully examined, it's making sure that it's internally consistent, that we have as little missing information as we can, and so that it's been collected accurately. And so the Data Coordinating Center is responsible managing all this data, and then they will be doing the actual statistical analyses of our final data set. So that's the Clinical Coordinating Center and the Data Coordinating Center. And like I said, in our center, in the Clinical Coordinating Center, it's only 4 or 5 people. In Data Coordinating Center, I think there's about 6 or 7 people that work for Maria at Pittsburgh working on the MINT trial. All right, then we have the clinical sites here. And you can see here, it says 80. This is an old slide, isn't it? Because I told you there's 148 centers, and that we initially started at US and Canada, but now we're all over the world. And then the final group that I should tell you about is what's called a clinical events committee. So here, our primary outcome, it includes recurrent acute myocardial infarction, and that is being adjudicated. What that means is that we have an approach to detect new heart attacks, both based on blood tests of the troponin results, EKGs, and then the clinical history about what happens with those patients. In anyone who's suspected to have an acute myocardial infarction after enrollment into the trial, after randomization, then the information related to that case, including the blood work results, the EKG, and any kind of relevant history findings from the medical records, are accumulated, and then they are presented to a group who decides whether or not that patient had a recurrent heart attack. And they're blinded to which group, whether they're in the liberal or restrictive transfusion group. So we have a whole process there to classify whether the patients had a recurrent myocardial infarction. Now, we're only adjudicating acute myocardial infarction in this trial. Many trials might have adjudicated other secondary outcomes, but we've chosen not to do that. So this is the general organization of the MINT trial. And here's an example. Here are names of people which aren't important for you to know, other than to see that that I'm the chair of the executive committee. Maria Brooks from Pittsburgh, as I told you, is running the data coordinating center. And then we've got a cardiologist from Duke, a critical care doc from University of Montreal, a cardiologist from Toronto, and we have representatives from France, Brazil, New Zealand, and then we have our National Heart and Lung Blood Institute project officer, Simone Glynn, who unfortunately just retired. But we are all part of this committee that meets there. And then we have the steering committee, which includes the executive committee, and then a whole bunch of other cardiologists, mostly, another one from Duke and Brown and New York Med and St. Louis University. Dr. Charluzzi is a blood transfusion expert from Pitt, and so forth. Okay, and Will Costis from Rutgers is a member of our team. And then my staff is Helaine Noveck and Karen Draggart, and Michelle Carmen, who's not listed here. And then we have lots of grants people who manage the financial parts of this thing. So you can begin to see how many people are involved. Now, what I haven't emphasized, and I don't think I have a slide on this, is that at the sites there is a site PI. That's a cardiologist almost always. They have a research coordinator or more, at least one, okay, who's responsible in recruiting the patients, collecting the data, and then sending it off to Pittsburgh. Okay, so at the minimum, each of the 148 sites have at least 2 people, and many of them have multiple research coordinators who are doing other projects, and they work as a team. So I want to emphasize, so when you go 148 times 2 at the minimum, you can, so 300 people from there, right? Another 20, 25 from here, right? And then if you go back to, the NIH team that's involved and the DSMB, okay, you can see that there are a lot of people, and this is the definition of team science for sure. And here are names which I don't think we need to go through. So I am done my formal presentation. You can see whenever I give a talk to the MINT trial people, they get my email and they have my cell. And I tell people I give them my cell because I actually want them to call me if they need help. And, I've gotten a modest number of calls, not as many as I wish I'd gotten, honestly. But, we try to make ourselves absolutely available to people to try to help them to successfully conduct this trial. So that is the overview. How'd I do with time? Probably went too long, but that's kind of how the MINT trial is working. Like I said, we have about 120 cases to go. I can't wait to finish this thing. That's all I can tell you. It's been a long, long journey, and we have planned. I don't know if we're going to pull this off, and maybe I shouldn't have this recorded, but I will. We're hoping to finish the analysis by the summer. The abstract deadline for the American Heart Meeting is the beginning of September, and we're going to submit the paper for simultaneous publication, and fingers crossed that the New England Journal of Medicine will take it. That's our game plan. I don't know that we'll make it by then, and we may have to push it back and go to a later meeting. But that's what we hope to do, and to make a big splash. And then we have 8 writing groups that are looking at secondary papers, looking at subgroups like people who have heart failure, people have had catheterization, so those who got catheter, those who didn't, chronic and acute anemia. We're planning to do an individual patient data meta-analysis with the other 3 clinical trials that have been done in acute myocardial infarction. So we'll be busy for a few years. Anyway, I'm happy to answer questions.
Okay, I'm interested in the sudden pivot. That was fantastic, by the way, so interesting, and I learned a ton about it, and it was great. I'm interested in the sudden pivot you did when COVID, destroyed your enrollments like it did for every clinical trial. So aside from, the logistical nightmare, I don't understand how your team came together to expand the team in other countries and all the IRBs and everything that had to be done and hiring people. And I'm also not understanding why it was easier to expand in those other countries than to expand in the US or Canada. But also and this is sort of a scientific question, are patients, like it doesn't matter where they live and what healthcare system they're in, like it doesn't, doing that expansion, like did you have to get it approved, and does it matter, and does it affect the integrity of the science?
Okay, well, there's a lot of questions in that comment. So look, the first question is expanding the trial to more sites, okay? And it takes a long time to get sites going. So, I was watching recruitment. This is actually before COVID, okay? But it wasn't that, it was probably 3 months before COVID. And I'm looking at recruitment, I'm thinking, we're not going to make it unless we get more sites. And, at that point, we did add some more US sites, but it's a question of who wants to partake. So I depended on our steering committee, who had friends who were involved with lots of trials, to refer hospitals to us, and we would talk to them and try to talk them into joining the trial. That's the first thing. So I would have welcomed to do it in the US, or we had most of the major medical centers in Canada, not all, but most of them. So I don't think there was a lot of opportunity to expand in Canada, but there certainly was a ton of opportunities in the US. Obviously 80 hospitals is not, I guess of those 80 hospitals, 60 were from the US, and there's 100, there's 600 more hospitals in the US and more, but that was who wanted to participate. And, we don't pay that well. And, the NIH trials don't pay that well. And so, they had to want to do it. We cover expenses, and I think we mostly cover people's expenses, but they're not making any money on this trial. That I can promise you. So at that point, it's saying, well, how do I expand it further? Well, a lot of this has to do with friends, right? It's like, so my steering committee, why did we go to Brazil? It was pretty, it's because, one of the members of our executive committee, his buddy, who is in the office next to his at Duke, is Brazilian, and he runs clinical trials in Brazil. His name is Renato Lopez, and he has a clinical trials coordinating center in Brazil. And so we approached him. He was next door to my Duke buddy, and suddenly we have 15 sites in Brazil who could participate in the trial. We have a clear link. We know all the people. They've been involved with other trials. So that's how Brazil got involved. Now, France, which I didn't go through this literature with you, but the French had funded a trial called Reality, which was in acute MI, very similar protocol, because I helped them put it together, which I'll tell you why in a second, and that they had published in JAMA. They had completed their trial of 660 patients. And I've been talking to them, say, how about if you join MINT? they already know the basic protocol. No one thought that their trial answered the question. It did not. Okay, it did not. You know, we think that we have good power at 3,500. I'd rather have 7,000, but you know, but 600 is definitely not enough to answer this question, and they didn't think it was either. And so we had been talking to them from the beginning of their study because I reached out to them and they reached out to me. I gave them our whole protocol. I gave them all our forms. I spent, you know, a number of hours on the phone with them, teaching them what we had learned from our MINT pilot about how to do their trial. So they went off and did their trial. They conducted it very well, got published in JAMA, which is fantastic. But they weren't, you know, they knew we needed much more data. So they agreed to help. And when their trial was done, you know, we rolled over their sites, not quite as cleanly like the day they finished the other trial, they started MINT. They didn't, it was about 3 months, but pretty quickly afterwards. And these were sites, they knew where their best sites were. They basically knew the protocol. We trained them because there were some differences. And so that was a great way to do it. They've enrolled 300 patients. They have been fabulous and they're great colleagues. And I mean, they're really first-rate clinical trialists. Then, you know, I'm looking at this, I'm saying, you know, more is better. You know, my point of view is you never have enough sites because.
And is this during COVID still?
Yes. Yeah,
okay.
We're still, some of this is still COVID. Yeah. Now, you know, a lot of the administrative stuff got done during COVID. They didn't start until later. And then, you know, we had contacts in Australia and New Zealand. They've turned out not to be as successful. You know, one of the Australian person who was leading it wound up getting a big senior job in the Australian government healthcare system. I don't remember what he's doing, but he kind of wasn't able to lead the trial. He's a very successful clinical trials. So we did not, you know, Australia basically we only have one site that's really doing much, and then New Zealand. You know, it's a small country. It turned out that some of their most productive sites in their other trials didn't really want to answer the question. They thought you should be using restrictive transfusion, so they didn't participate. So we only have, I think, 6 hospitals in New Zealand, and you know, so it's not been that. They haven't randomized that many patients. But so, you know, basically, you know, you try to find high productive sites, and you go to where people have a history and where people know them and they're willing to do it. And you know, you just keep trying. That's all I can tell you. Now you had a second question, although I'm not sure I answered that question, Nancy.
No, you did. But so NIH was fine with you going outside of what you had proposed to do in terms of where you were going to recruit?
NIH had to, if you include any foreign sites, NIH has to approve it. Has to be approved by the State Department.
This is all after the fact.
and this, well, no, it had it before we could.
No, I know, but after you already had your protocol going and everything.
Oh yeah, and you know, this was So but you know, the NIH has a long history of funding non-US sites. They invested a ton of money into this trial, and they wanted to be successful. And I think I needed to convince them that we needed the help from foreign sites to do this, and they agreed to do it.
Great.
So I have a question. Congratulations, Jeff. It's such an impressive body of work here. When you think about sort of the coordination and leadership of this team science effort, what are some of the markers of success? What are the metrics that you look for to determine the effectiveness, not of the clinical trial, but in terms of how you're assessing the effectiveness of the team dynamics, the team performance?
Well, I mean, you know, Ralph, really the main measure is, you know, are you recruiting? Are you implementing the protocol? Are you getting good follow-up? Which, by the way, we have 97% follow-up for our primary outcome, which is amazing, actually. You know, to me, it's like any other relationship that you have professionally. You want people who are interested in a topic. You want people who have the skill sets that you need, and then you need people who want to play as a team and are easy to work with. And I'm really careful about the latter point, okay? Because I've had prior experiences in my other trials where we had personality issues, and it is totally destructive to a way a group works. And it was so painful, the last study, dealing with some of the nonsense that we were dealing with. So when I was choosing a data coordinating center, I interviewed 3 or 4 groups, and before I settled on the Pittsburgh group, I flew out there and met them personally. I didn't know them before, and I had gotten great recommendations from friends of mine who had worked with them, and I had recommendations from other people, from other maybe higher prestige institutions. But they weren't interested in the project. I didn't feel good about them in terms of my relationship with them. And so I'm super careful about finding people who are highly competent, but people who I can work with, and honestly, who I could become friends with. And, that's how you get projects done. These things are a ton of work. I mean, you just can't imagine the amount of hours that you put into this sort of thing. Hell, the amount of worrying I do is worth, I mean, I worry about recruitment every night. It's like my sleep pattern is directly related to the number of cases we enrolled that last few days. And, we only got 1 case yesterday, so I woke up early today. What can I tell you? And so I am super careful about who I choose to work with. And so our steering committee, I mean, it's a fabulous group of people. Now, in terms of leadership style, I mean, you sort of know me, but I don't think I know everything. For Christ's sake, hell no, not even remotely. I have people on the steering committee that are much more experienced in clinical trials than I am. Now, I am the content expert, no doubt. And I, not to brag, but it is a fact that if you're invited to write a New England Journal invited review, it means you have the standing in the community, so that when I go to talk to people, they're not questioning whether I'm an expert in the field. Okay, that's it's one of the reasons why most trials are led by more senior people, because you don't develop those reputations, when you're in your early career. It takes time to have that track record and have that senior experience to have that reputation. So I think that was important from that perspective. And then, I'm sure you heard enthusiasm in the way I present this stuff. And so it's a heartfelt, it's not show, it's the real thing, okay? And so, I'm highly enthusiastic. No one doubts that I don't work incredibly hard on this project. So people are willing to work hard for us. They're absolutely willing to work hard for us. So our steering committee, I mean, some of them have worked together for years. So, John Alexander and Sean Goodman do trials all the time together. They kind of got me together with them. Paul Hebert, who he's kind of the initial guy who developed the original clinical trials comparing thresholds. We've been friends for 20 years, 25 years. So some of this is building, bringing your friends in who are really good. That is really helpful, but we all work really, really well together. And I really think that's key. Now, the other style thing that I do, and I don't think most trials do this, is we cannot we're totally dependent on the sites to get our numbers, right? Totally dependent on them. So I said earlier, they have my cell phone. I tell them that I want them to use it. If they have questions, they call me. I pick it up all the time. And the problem today is that most of them are from someone selling you something, not related to the trial. But I still pick it up. Once this trial's over, I'm going to stop answering those calls. But you know, I don't know who's calling, and their numbers I don't recognize. And a lot of times it's a coordinator or a doc from one of the hospitals, and I want to be there for them and ask questions. They know that, and they hear it loud and clear. We do lots of training, and every time a patient is enrolled in this trial, I send a thank you note with an emoji. I got about 25 emojis, from wow to thank you to clapping. I know all this sort of ridiculous stuff, but the point is, I say thank you, and I can't do this trial without their help. The success of this trial is dependent on them, and so I push them. I mean, please, please, please. I mean, I can't do it any other way. I don't pay them enough money to probably make a difference in in their programs. But and then the other thing we've done, and we may have done this, we may have timed this wrong, but we have writing committees in which anyone who has made any meaningful contributions to recruitment can volunteer to be on a writing committee. And so we have a lot of writing committees. I tried my best to put people on their first or second choice. We have conference calls where people, we're putting together the papers. We're putting the methods papers together. We're figuring out how we're going to define things. We're putting the tables and the figures together, all with the idea of trying to do a lot of preliminary work before we finish the main manuscript, with the idea that we can then turn to these second manuscripts, and the coordinating center, the data coordinating center, already has a lot of the programming done to produce these results. So trying to get their cooperation has been, look, there is something in this beyond me giving you a little bit of money and a thank you. There will be some scholarly opportunities here, and that's the other thing that we tried to do to make it worth people's while, if you will. And then I will, when we have our primary manuscript, I will put as many authors on that as the New England Journal will let. And I'm figuring we're going to have 40 plus authors on this thing. And now, the only people, they have to be sort of part of our leadership team, which represents 20 plus, right? And then, but I want to have all the site PIs in places that enrolled pretty well for the trial. I want to give, that's my way of giving back. And if this paper gets to New England Journal of Medicine, that's a big deal for all of us. And even if they're one of 40, it's still a big deal to be an author in New England Journal of Medicine paper. And if it doesn't get into New England, it'll get into Lancet or JAMA. It'll get into one of the top tier journals. I'm not worried about it. I'm sure it will. But I think we've got a shot at New England. And so those are all the ways that I try to create.
Great job. Thank you.
In a group process, people can call me, and we listen to each other. These are not Jeff telling people what to do. That just does not happen. There's stuff that we're doing that honestly I would have preferred not to, but the group consensus was to do it this way.
Thank you.
Yeah, I think we're about out of time, but I just we all want to thank you so much, Jeff, for presenting to it today. And these were really so valuable to hear your experiences, your insights, and your lessons learned, including how you've made it so successful despite the challenges you faced. You clearly have an impressive team. You have clearly articulated goals, so we expect nothing less than a New England Journal paper, and we have it here on record. Good luck with finishing.
I think you better edit that part of this presentation.
Yeah. We'll see. Yeah, we'll do our best. But so yeah, good luck with finishing enrollment and with whatever you find. I'm very excited to learn. I'll just say the next Team Science seminar will be in a couple months, and we'll hear from Joel Cantor and the team from the New Jersey Population Health Cohort Study. And then finally, if if you're watching and you have questions about how to form an organized research team, about how to foster team dynamics and performance, about leadership or resources to do team-based research, you have Jeff Carson's cell phone, but you can also visit the NJAX Team Science website and request a consultation. So
thank you, Dan.
thank you again, Jeff, and
Thank you. Fascinating.
Thanks,
Great.
Jeff.
You're welcome. Bye, guys.
Bye-bye.